I know everyone at this table loves taking care of patients and loves being sort of coordinator within their own community, not only on a national level, but we each are our regional resource. How do we interact? Tara, I'll pick on you first. How do we sort of interact, or what's a good way that we can take care of patients with metastatic colon cancer using all the resources? I think of it as a team sport. How's your all's team work?
Yeah, I completely agree. So every patient is brought to our GI tumor board, which is exclusively just colon cancer. And who's at that tumor board are the medical oncologists, the radiologists, the pathologists, the surgeons.
IR, do they show up?
They show up.
You must serve donuts.
Snacks help.
Snacks are good.
But I think that really helps the best interest of the patient. Versus them seeing 6 different appointments, we can have everybody together decide on what's the easiest thing. Now, if patients are being seen in the community, then what we do is we call the oncologist, we let them know what we feel is the most appropriate, and we send them back. And we work as a team approach. I love it when I just get emails from oncologists because it's a great way to correspond, and you can answer it quickly, and we're helping the patient.
Yeah, and can you all talk a little bit about partnering with the community? I mean, we're good at what we do. Patients come and see us. They're like, are you going to do it better than the community? The community therefore gets mad at us because they stay with us. How do we, as give it sort of our perspective from the ivory tower, if you will, of that interface and how we really interface with the community? How does it work for you guys?
So at least at MD Anderson, the majority of patients are from out of town to begin with.
They've flown in.
Mm-hmm, they've flown in. And so I really encourage, a lot of patients are willing to stay with me and fly back and forth, but I actually discourage that because I would prefer that they get their treatment closer to home. Yeah. I feel the patients do fare better overall in regards to their mentality, how they tolerate treatment, they're continuing to work. Yeah. So I try to send them back home, and then I just coordinate it with their outside physician.
You got a mainline patient who gets sent downtown. You're charming. How does that work?
Of course. Well, I've been at Penn for 36 years, so I have a reputation in town. And the truth is that we're not seen as a roach hotel where you check in and you don't check
Never
out.
Check out.
That's not a good way to be. For some patients, we do encourage them to stay. If they have a rectal cancer and they're coming from a place where they don't have a good board-certified colorectal surgeon, et cetera, that's a patient that we push a little bit toward making that commitment. For somebody with metastatic colon cancer or fairly routine care, like with Cathy, we encourage them to be closer to where they get their care. So if it's a simple episodic surgical procedure or an IR procedure or something else, yeah, we'll push a little bit to stay. But as we like to use emails, and I like being curbsided. We all like that.
Yeah, it's sort of flattering when we get that email about how would you take care of this or that. Yeah, but we do partner more and more with our community folks. I mean, you guys in Columbus, I'm sure you guys in Phoenix do that too. But these formal partnerships where we're even doing clinical trials with our community partners and things like that. But we do have unique resources around IR, around surgery that sometimes are worth coming in. So is that?
Yeah, I mean, I think there are specific cases where the patients and even the referring physicians feel more comfortable with us assuming care. I mean, the example of rectal cancer, specifically the surgical component, sometimes the radiation component. I mean, one thing I tell my fellows, when they graduate, especially if they stick to academic medicine, I say, you're going to go from one day being a fellow to the next day being the GI cancer expert. The doc in the community has 20 years expertise seeing more colon cancer patients than probably all the GI oncologists combined. The fact that you just, are a specialist on day one doesn't make you any smarter or better. And it's very important for us to make our community oncologists feel that we're just their partners. We have a different level of expertise, and we can help with things, and we partner with research, and we can bring more awareness to them. But I think optimally, as everyone says, optimally for patients, they're better treated in their own community, surrounded by their loved ones, closer to home, and others except in very few instances.
And the parking's cheaper too out there.
Depending where.
I
Depending
know
where.
it's true at Georgetown. As,
Phoenix and
I suspect-
Columbus, it's free.
It's free, yeah.
But it is really a team approach with
It is.
the outside oncologist. I mean, you get to know them. You actually become quite friendly with them, and so you have this real partnership.
And the patient sees that too. I think
Yes.
that relationship of back
better
and
for the
forth and
patients.
trust.
Yeah, it makes the
really is.
patient comfortable.
Yeah.
So then they have no, the issue is, what if they get sick? You don't want them flying or traveling to see
Exactly.
you. You want them to see their local doctor,
And John, just to, although the cooperative groups are certainly having troubles financially and otherwise, they still represent an enormous clinical resource, and more than 50% of the patients who enter clinical trials in the cooperative groups don't come from the academic centers that write the studies, they come from the docs in the community who actually take care of most of the patients.